Hello, everyone. We are very pleased that you have all joined us today. This is Chris Putnam with Exosome Diagnostics. And as a reminder, all participants are in listen-only mode, but please feel free to enter your questions in either the question box or the chat box at the bottom of your screen. It is my pleasure to introduce our speaker today, Dr. Ronald Tutrone. Dr. Tutrone earned his Bachelor's of Science degree in Chemistry from the College of the Holy Cross in Worcester, Massachusetts. He continued his education and obtained his MD at Rutgers Medical School. He completed his urology residency at Brigham and Women's Hospital in Boston. Dr. Tutrone is the chairman of the William E. Keller Endowment for Urological Research and the medical director of Chesapeake Urology Research Associates. He's been voted top doctor by Baltimore Magazine 12 times and a super doctor for urology in the Washington Post magazine for Washington, D.C., Northern Virginia, and Baltimore. Dr. Tutrone has authored numerous articles in urology literature. He has been the principal investigator in more than 200 clinical research trials, including the CareFirst clinical utility study that you'll be hearing about today. Now I present to you Dr. Ronald Tutrone. Thank you, and the floor is yours.
Thank you very much, Chris, for that kind introduction, and it's a pleasure to be here today with everybody. Thank you for taking the time out of your busy schedules to hear me speak on this. So I just want to give you a little background first on what this is about and how this came about happening. I do conduct clinical research for Chesapeake Urology and United Urology Group. We're a large private equity-owned urology group with 150 urologists in 5 states in the United States. I do have a busy clinical practice, but at this point, about 60% of my time is spent conducting clinical trials. We're over about 70 active trials going on, and I love doing this. In June of 2017, while I was recovering from a fusion surgery on my back, I was in my yard and I got a call from Exosome Diagnostics to participate in a trial. They were trying to create a trial looking at their a new urine-based gene expression assay that may reduce unnecessary prostate biopsies and better select patients who are at risk for high-grade prostate cancer and may need a biopsy. But what was most interesting to me about this whole thing was that this was being funded through a collaboration with CareFirst, Blue Cross Blue Shield of Maryland. Most of the trials I do are pharma funded. This was the first time that I had done one that was really being looked at by a large insurance carrier, the largest in Maryland. And they wanted me to do a prospective randomized 2-arm trial with a blinded control arm, which was unique in and of itself. Most assay trials don't have a blinded arm. So I did jump at this opportunity, and this is what led me here. And I'm going to talk a bunch about this utility trial. But first, let me proceed with what the agenda is here today. I'm going to talk about the need for this test and why it's so important for us. And I'm going to talk about what exosomes are and the ExoDx risk assessment. I'm going to briefly talk about the trials that got this assay validated. And then I'm going to get into the details of the clinical utility trial, which I conducted here in Maryland. Talk about some of the recent milestones, short clinical cases, and then give a summary. So from the 30,000-foot view, we're addressing on a macro level, what's needed here. We know that there's about over 200,000 men diagnosed with prostate cancer, 35,000 prostate cancer deaths, and we perform about over 1 million prostate biopsies in the United States every year. And really, many of those are unnecessary, or about 80%. And of the 200,000 men diagnosed with prostate cancer, 65 to 75% of those biopsies will have benign or low-grade disease. And they're not often, we take it for granted, but when you're on your side with an ultrasound probe in your backside getting a biopsy, it is uncomfortable. Many of the patients will have blood in their semen for weeks afterwards. There is some pain associated with it. And there is a high incidence of sepsis of 1.5% to 2%. And with the increasing prevalence of antibiotic-resistant bacteria, it can be dangerous. So it would be nice to really select out those patients who need the biopsies. And historically, as a urologist, when I came out of training, when I had a patient with a single core of Gleason 6 prostate cancer with 20% in it, he needed his prostate removed. And that was a disservice to these men, but it wasn't a fault of ours. It was just we lacked the knowledge. And I sit and I tell most of my patients that most of you guys are going to die with prostate cancer from it. But we didn't know better, and we way overtreated this disease. So now we've advanced where we place patients into risk categories of very low, low, intermediate, and high. And as you know, almost 40% of patients now who are in the very low and low risk are put on active surveillance protocols. But again, that protocol involves frequent biopsies, which is in and of itself would be nice if we could avoid that. It would be nice if we could avoid diagnosing these low-risk prostate cancers and not put patients through the angst of having repeated biopsies on an active surveillance protocol. So there's a real need here on a micro level to help us select those patients who can avoid biopsies. So this is just an example, anecdotal, of 3 patients who are roughly in mid-60s, and all of them have slightly elevated PSAs in the 4+ range. How do you discriminate which patient to do a biopsy on? We use standard of care based on their age, their race, their family history, PSA velocity. But that's all we've had to go on. And so it really would help if we could discriminate which of these patients are really at high risk for having a high-grade prostate cancer. And that's where the exosome epi test comes in. So there's a big change in medicine. We've gone from morphological diagnosis to molecular diagnoses. We now have different assays that can help us discriminate higher risk cancer, like the Oncotype test, the Decipher, the Prolaris. But the problem is that oftentimes there's a lack of tissue, enough tissue, and there's a lot of heterogeneity, as you know, in the prostate. There's multifocal areas of cancer in there, and it could be a biopsy error missing the high-grade cancers. So we are moving from tissue-based biopsy now to liquid biopsies. Liquid biopsies are less invasive, more accessible, easier to sample, lower cost, and they give you real-time insight to longitudinally track disease. As I will show you, it's easier to do a clinical trial on an assay, a liquid biopsy, so it's less expensive. You can bring it quicker to market, get approval through the FDA. It can also support stratification and monitoring of disease states. And you could get, and so, you know, if there's you could monitor patients for biochemical recurrence. You can monitor patients for disease progression. And you could get the right treatment to the right patient at the most appropriate time. And EPI is the first liquid biopsy test now approved. There has been a gold rush for liquid biopsies with circulating tumor cells and cell-free DNA and exosomes, but overall, exosome technology will always outperform cell-free DNA or circulating tumor cells. There was a recent article I just read in this month's Journal of Urology that talked about circulating tumor cells in patients who are post-radical prostatectomy. They looked at their serum for circulating tumor cells and found that those who had a higher concentration of circulating tumor cells had a higher risk of biochemical recurrence than those patients who had lower concentration. So there is a need and a great, this is an exciting area and time to be in with these liquid biopsies. So what are these exosomes? And exosomes are extracellular vesicles with a double lipid layer that emanate from the endosomal compartment of a cell. And they're secreted by all living cells into all biofluids. So they can be in saliva, semen, blood, CSF, and they play an important biological role in health and disease. They're key for intracellular communication. They can induce angiogenesis, stimulate tumor growth, they can blunt the immune response, and they're important for communication between cells. They play a key role in many diseases, cancers, inflammatory neurodegenerative, cardiovascular. They've been studied in Parkinson's, Alzheimer's. They can be used in, they're exploring this for chronic traumatic encephalopathy with brain trauma. And it'd be nice if we could follow some of these football players by looking at their CSF and studying their exosomes. This is all future. So these exosomes are a treasure trove of biomarkers. They are very rich in RNA, proteins, and DNA from the native cells. So they're very stable with the double lipid layer, and they're disease-specific macromolecules that have the native configuration of the cells of origin. They can be looked at as tweaks, cellular tweaks. And these cells, all cells release them, and they can release up to 20 to 30,000 exosomes per day. And they're important for communicating to other cells and contain this rich information with RNA, DNA, and proteins. And they can be collected from any biofluid. So they're released by eukaryotic, prokaryotic cells. They play an important role in health and disease that's just being explored, and they can deliver molecules not normally secreted from the cells in very stable packets. They are used in cancer to stimulate tumor cell growth, inhibit immune cells, and stimulate angiogenesis. When you look at the size of these, they're really tiny. They are about the size of a virus. Smaller than bacteria, much smaller than platelets, and much smaller than cells. These are tiny particles. So these exosomes enable us to detect disease earlier and longitudinally track disease. They provide real-time data, snapshots about what drives this individual patient's condition and their responses to therapy. They're non-invasive to collect, easy to collect fluid. And they overcome the heterogeneity like you see in prostate cancer. Unlike CTCs and cell-free DNA, they overcome the noise, the signal-to-noise challenges faced by that. It's very complicated collecting CTCs and cells. This was first reported by Johan Skog, when he is a Swedish PhD. While he was at Mass General Hospital, he first reported on this in a paper in Nature Cell Biology, where he found that exosomes were very important in the communication in glioblastomas. And since 2008, there has really been a surge in the literature of publications on exosomes. So what makes the ExoDx urine-based prostate test unique? And to me, what's great is it takes PSA out of the picture. It does not involve PSA. It can be used as an adjunct to PSA in your algorithm. It targets prostate cancer-specific biomarkers, the ERG, PCA3, and SPDEF genes. Very simple to collect, doesn't require a digital rectal exam, and it was done that way because they first saw this urine-based test as being something that a patient could do at home. And so they wouldn't need a digital rectal exam, and that's the way it was studied. It's non-invasive, and it's really targeted for men who are over 50 in the gray zone with a PSA of 2 to 10 who are being considered for prostate tissue biopsy. And it can assess a patient's risk for high-grade prostate cancer. And I'm going to get into the validation studies that do it. But first, I want to talk a bit about the collection. It's a little tricky to collect it. As I said, all cells will secrete exosomes. So when you collect urine, that urine you collect from the bladder may contain exosomes that come from the nephrons in the kidney, the urothelium in the ureters or the bladder, as well as the prostatic urethra where the exosomes excreted. So what's important with this test is you collect the first 15 cc's of urine, which is going to be rich in the exosomes that are excreted by the prostate. And they developed and patented a very unique device called the colipy, as you see here. And the colipy, a man will place his penis in the wide mouth of this device, point the short end into the toilet. They'll urinate into this device, and the first 15 mLs will be captured into this device, and then the rest can be discarded into the toilet. So it's a little tricky and takes education to show the patients how to collect this properly. They do have a proprietary ultrafiltration membrane that selects out these exosomes into this urine collected here. It's important that patients are also instructed that they cannot void within an hour of collecting the urine. So you have to have patients not void for an hour to get this. They extract the RNA from these exosomes. They use a multivariate algorithmic analysis using reverse transcriptase polymerase chain reaction to augment the RNA. And then what you end up is basically with a score, a binary score, with a cut point of 15.6 above, excuse me, above 15.6 is a positive test. Below that is a negative test. Hold on one second. Sorry about that. So unlike the 4K test and the Phi test, this gives you a cut point. Those tests do not give you that cut point. It varies, and they all involve PSA. That's a big downside of those other tests. I use a lot of them, but they do involve PSA. This is standalone test looking at the 3 genes in the urine. So using a cut point of 15.6, you can tell a patient that a score may vary from 0 to 100, but if a patient is below the cut point of 15.6, you could say to your patient that you have a 92% chance of not having a high-grade prostate cancer, meaning a Gleason score of 7 or higher. And you can defer biopsies, taking into account other risk factors such as age, family history, PSA velocity, race. Similarly, if their cut point is above 15.6, it may indicate risk of a high-grade cancer, and you would choose to proceed with a biopsy. And again, I'm going to get into this whole statistics of it, but a sensitivity of 92% means you only have a false negative rate of 8%. So the negative predictive value of this test is 91.3%, and that's the true negative over the true negatives plus the false positives. So you don't have a lot of the negative predictive value is very important here in this test. Now I'm going to get a little more into that. So the EPI test has gotten broad acceptance. In May of 2019, it was included in the NCCN guidelines for screening and early detection for prostate cancer for both initial and prior biopsy patients. The test did get positive local coverage determination by Medicare effective December 1st of 2019. And as we know, the commercial carriers often will follow in time once Medicare gives it coverage. It has gotten broad Blue Cross Blue Shield and CareFirst coverage. They did get a 10-year Government Services Administration Award for the VA healthcare system effective March 15th of 2020. And I learned that this covers over 9 million lives. This is all government employees. So it is broadly accepted. The test is available in 50 states. So I want to move on to the data that supports use of this test and the validation study. So the first validation study was published in JAMA Oncology in July of 2016 by Jim McKiernan, and the follow-up one was in the European Urology Journal in August of 2018. And these two intended use patient populations, and that is men over 50 with PSAs of 2 to 10 presenting for initial biopsy. And this represents more than 1,000 patients from over 40 urology clinics in the United States. And what they showed in these validation studies is that they were able to show a 27% reduction in unnecessary prostate biopsies, and the EPI test is able to discriminate between high-grade Gleason 7 or higher and low-grade prostate cancer. So just to briefly touch upon this grading system, we've now accepted the ISUP, the International Society of Urologic Pathologists scoring system, which grades it 1 to 5. A grade 1 is a Gleason 6. Grade 2 is a 3 plus 4, 7. 3 is a 4 plus 3, 7. 4 is an 8. And 5 is a 9 or 10. So we classify high-grade disease as grade group 2 or higher, so a Gleason 7 or higher. And this is where the EXO test was validated and showed that it improved the identification of patients who are Gleason grade group 2 or higher, 7 or higher. So PSA, using PSA alone as a predictor for high-grade prostate cancer, does perform poorly in that gray zone of 2 to 10. When your patient has a PSA of 20, 30, 40, it's a no-brainer. They're going to get a biopsy. But in this gray zone, it's more difficult to decide who to biopsy. And a lot of these assays and trials will look at patients who've had repeat biopsies or have higher PSAs, not in this tight window of 2 to 10. And that can boost the negative predictive value and increase the sensitivity falsely. These two validation studies did not do that. So they looked in a tight window of 2 to 10, and what we found, the term that gets used here is the area under a curve. The AUC for PSA is not great. It's a 0.55. A perfect test, which has 100% specificity, 100% sensitivity, has an area under the curve of 1.0. So in contrast to just using PSA alone, the ExoDx test from these validation studies had an area under the curve of 0.71, which is quite impressive because that does not take into account other factors. It's a standalone test. When you optimize the standard of care, so you take into account the age, race, other risk factors, family history, PSA velocity, that increases the area under the curve of PSA from 0.55 to 0.63, but the EPI test still beats that. The prostate cancer prevention trial calculator, which many of us use, has an AUC of 0.62. The European registry screening for prostate cancer has an area under the curve of 0.58. All of these still are not as effective as the EPI test in detecting high-grade prostate cancer. So this curve shows you graphically the area under the curve for discriminating high-grade prostate cancer. And you see here this green line is PSA with an area under the curve of 0.45. If you take any point along that PSA and compare it to the exosome EPI test, the EPI test has much higher sensitivity and the area under the curve is much greater. When you look at the optimized standard of care, which is using PSA with other risk factors, it increases the AUC, and even adding that SOC, the standard of care, to the exosome test doesn't really improve it that much. So the test alone is far better than PSA. This is the data from the validation trial, the first validation trial done in JAMA by McKiernan. And I want to really focus on this chart a little bit here because it shows you all of the patients, 519 who underwent prostate biopsies. The sensitivity of this test was 92%. And what the sensitivity is, if you look here, those patients who have a cut point over 15.6 who had a grade group 2, a Gleason 7 or higher, was 136. Total 148 patients. So the sensitivity is the true positives over the true positive plus the false negative. The false negative is the 12 patients who had who had an EPI cut point under 15.6. So 136 over 148 gives you a 92% sensitivity. The negative predictive value, which is the true negatives, those patients who had an EPI cut point under 15.6 and had a negative biopsy or a Gleason 6, that was 126 out of 138. So the true negatives over the true negatives plus the false positives, and that gives you a negative predictive value of, the false negatives, gives you a negative predictive value of 91.3. So look, let's focus on the false negatives here. There were 12 patients who had an EPI score under 15.6. When you look at these and break this down, the majority of these false negatives, the 12 patients, 9 of 12 were Gleason 3 plus 4 with less than or equal to 3 positive cores. Okay, so these were grade group 2 patients, 9 out of the 12. Many of these patients, as many of the urologists who are listening here know, there are many patients who are diagnosed with Gleason grade 3 plus 4 who we will put on an active surveillance protocol, and we'll consider them low risk. If they have 2 cores of Gleason 6 and 1 of Gleason 3 plus 4 with only 5 or 10%, we will opt to place those patients on active surveillance. So if you take these 9 patients out of this 12 false negatives, that gives you a negative predictive value of 97%. And you consider high grade a 4 plus 3 or higher, it increases that negative predictive value to 97%. It took me a while to figure out all these graphs. Overall, there was a high grade biopsy of 29% out of those 519, 148, and the EPI test was negative in 27%, 138 out of the 519. So what's important to point out here is the EPI test with the cut point under 15.6 only missed 3 out of 138 Gleason grade 3 or higher, grade group 3 or higher. I hope I made that clear. Took me a while to get that. So I want to look now at a subset of patients from the Kiernan trial and from the validation studies who had prior biopsies. Right, there were 229 patients who had prior negative biopsies. They utilized a cut point of 15.6, and these patients had an average PSA a little higher than the validation study, 6.1. In the validation study, it was 5. Of those patients, 31% had a Gleason 6 or higher. They were diagnosed with prostate cancer, but the high-grade cancers, grade group 2 or higher, were only 12%. Compared to in the validation trial, 29% of the patients had a high grade group 2 or higher. So prior negative biopsies will have a lower high grade prostate cancer detection. When you look at the area under the curve for those repeat biopsy patients, it held up. It was a 0.66 compared to PSA of 0.54, had a negative predictive value of 91.5%. So the EXO test still outperformed PSA as a calculator for high-grade prostate cancer. Here you see the PSA curve from the repeat biopsy test, and here's the EXO curve, the higher AUC. Now, what was interesting is they looked at an exploratory cut point of 29.5 in these patients. And when they used that, the negative predictive value increased to 94%. But most importantly, it meant you can avoid biopsy in 55% of those patients. And graphically, I could show you that on a waterfall plot. Each of these lines represents a patient. And using the EPI score cut point of 15.6 here, if you use a 29.5, you're really only going to miss, and the yellow and the red are grade group 2 or higher, you're only going to miss 4 patients here. And 3 of them are grade group 3 or higher. So using the proposed cut point of 29 in repeat biopsies, it avoided biopsies in 56% of patients. And you see most of the grade group 2 or higher are concentrated in the higher EPI scores. Okay. So I thought that was interesting. So now moving on to the trial that I initially told you about that they wanted me to do with CareFirst Blue Cross Blue Shield. This paper was recently published, and it was the clinical utility of the exosome-based test in men presenting for initial biopsies with PSA 2 to 10, age over 50. This is the only prospective prostate cancer biomarker utility study that was done with a blinded control arm. And that was important because we have some very interesting findings. When they came to me, they asked me to enroll about 1,000 patients. And I said, that's impossible. I'm just one urologist. They said, well, no, you have 75 urologists here in Maryland. You could do it. And so this was a bit of a Herculean task to do because I had to enlist 72 urologists at 24 different clinical sites with their MAs and enroll them as principal investigators and clinical research coordinators in order to generate this volume of patients. So it was really an incredible task, and it's hard for me to express that, just how difficult this was, because I had to train all of these urologists in good clinical practice in order to certify them as principal investigators, and we had to really do a lot of education through webinars like I'm doing now, and I wasn't used to this. I got pretty good at it after this COVID-19 thing, but back in 2017 when I was doing it, I really was not very good at doing these webinars. And they wanted these 1,000 patients to be enrolled within a 6-month period. I've never enrolled that many patients in any trial, let alone in a 6-month period. So we did manage to do this, and I'm very proud of that. And I appreciate, I have to do a shout out to my research team. I hope some of them are on the line. I know Heather Thomas is the director of research, and she was very instrumental in negotiating a contract and budget to do this. And I had a great team who went out and taught all of the MAs and the physicians how to become investigators. And I really have a big thank you to Chesapeake Urology who supported me in doing this. The docs were all very excited to do this. The objectives of this study was really to show, does utilization of the urine epi test reduce unnecessary biopsies? And their goal was to see a greater than 15% reduction. Does the use of this test increase the compliance with biopsy recommendation or deferral recommendation? And does it influence the shared decision-making regarding biopsy between the physician and the patient? So the key outcomes here showed we did reduce the unnecessary biopsies by 23%. We improved compliance to both proceed with a biopsy and defer biopsy, as I will show you with the data. And it detected, what we found most importantly, is utilization of this epi test detected 30% more high-grade prostate cancer in the epi arm versus the standard of care alone. I want to move on to the study design. We had, in the end, 458 patients in the epi arm, 484 in the control arm. All of these patients gave a urine specimen, and then in the epi arm, the test results were used in a shared decision process with the physician and the patient to choose whether to proceed with biopsy. In the control arm, the physician and the patient did not get the epi results, and they just used standard of care to make their decision on biopsies. So looking at the demographics in the trial, there were 458 in the epi arm, 484 in the control arm. The average age was 64 to 65. They're pretty evenly matched. The epi score average was 28.8 in the epi arm, 27.9 in the control arm. Remember, they did not get their scores here. Interesting point here, and this points to our demographics, 22% and 24% were African American. This is a huge advantage to this study because overall nationally, about 13% of patients on trials or fewer will be African Americans. So we had a very large representation of African Americans here. The prostate digital rectal exam was only abnormal in 5%. So patients were enrolled based on standard clinical criteria, over 50 with a PSA of 2 to 10 who we are contemplating doing a biopsy. Physician will fill out a pre-epi questionnaire, and then the patient would have the urine test and were randomized, but they were randomized into the epi arm or control arm, but only the epi arm received the results. No one was notified in advance whether they were going to receive the results or not. So we were all blinded to that. Then in the epi arm, the urologist would receive the result, and review that with the patient prior to making a final evaluation to proceed with biopsy or defer biopsy. And in the control arm, the urologist got a notification that they were not getting the epi test, and they continued the discussion with the patient per standard of care. Post-biopsy, they filled out a clinical questionnaire saying how they found the test. Was it helpful? Did they find it useful in discussing this with the patient? And I'll get into the results of that. So let's first look at the epi arm. There were 458 patients who received the results. 93 were below the cut point of 15.6, so 20% had an epi score less than 15.6. And of those patients, 63% of them, or 59 out of the 93, were recommended to defer biopsy. So remember, this is a clinical utility trial. Physicians could do whatever they want. Patients can choose to proceed or not. It wasn't rigid where if you were less than 15.6, you deferred. This is a utility trial, and that's important. So if you look here, 34 out of those 93 chose to proceed with biopsy. And you say, well, why did they do that if their epi score is less than 6? And that would be based on standard of care factors such as age. A young guy with a PSA of 4.5 who's 40, you're going to probably biopsy him, even if the epi score is less than that. Age, race, PSA velocity, family history, and other tests we utilize. Physicians were at will, they could order 4K tests or PHI tests, and so those were utilized. Of the patients who were recommended to defer biopsy, 54 out of 59, or 92%, were compliant with the physician recommendation. So that met one of our objectives. Will it increase compliance? And 92% were compliant when we recommended deferral. The remaining 37% recommended biopsy, and of those who we recommended biopsy, 44% ultimately decided to defer. So overall, 69 out of 93, or 74% of the patients with an epi score less than 15.6 chose to defer biopsy. In the arm where the score was above 15.6%, 72% chose to proceed with biopsy. Now, of the 80%, 365 patients, 87% were recommended biopsy. So you say, well, why did 13%? Why were we recommending deferral? And that, again, will take into standard of care factors. If the guy's older and the PSA velocity is low, his PHI score may have been low, no family history, the epi score may have just been marginally elevated at 19 or 20. These are the patients who would fall into this deferral category. But of those who we recommended biopsy, 72% chose to proceed. So that, again, was one of the objectives of the trial, to show, does this epi test utilization increase compliance? And in fact, it did. 72% chose biopsy. In the group, that 13% who were recommended to defer, 23% of them chose to proceed anyway. Okay. Now, what's not shown is the standard of care arm. This looks at the epi arm. In the control arm, where they did not receive epi results, it was very interesting that only 39%, chose to proceed with biopsy. And that, we scratched our heads with that one and said, well, why is that? Let me just back up here because I want to touch upon that. Why did only 39%? So we went back and looked historically at 3 preceding years with patients who had a PSA of 2 to 10. And in fact, in our group, we did a large database search. 48% of patients who were recommended to proceed with biopsy because the PSA was 2 to 10, only 48% chose to proceed with biopsies. So the standard of care, again, only 39% chose to proceed. So this next slide is a little difficult to follow, but I want to go through it with you. It's very interesting. So it shows you that the biopsy decision rate here, which is in the blue line, what percentage of patients chose biopsy based on their EPI score. So it's plotted as a function of the EPI score. And here below in this blue shaded area is from the validation trial, which shows you the range. The blue area shows the high-grade prostate cancers from the validation trial based on the EPI score. So what you see is with an EPI score in the 0 to 10 range, it's a less than 10% risk of high-grade prostate cancer compared to the EPI score above 40, which gives you a greater than 40% chance of prostate cancer. So it's logarithmic. And so what we saw in our trial, in our utility trial, that in the patients who had an EPI score less than 15.6, only 26% of low-risk patients proceeded with the biopsy, which when you compare it in the control arm, 39% had biopsies across the board. It didn't discriminate utilizing the EPI test. But when we utilized the EPI test, it decreased the biopsy rate to 26%. Okay? And as we got higher, you see the higher EPI scores, a higher percentage of patients chose to proceed with biopsy. All right? So when we use that cut point, it supported deferral of biopsy. And when it was above 20, a higher percentage of patients, it was easier to explain this to the patients and tell them, hey, you know what, there's a warning sign, you should have a biopsy here. So the EPI score over 30 indicates an increased risk of finding high-grade prostate cancer. And in the control arm, the prevalence of high-grade prostate cancer was 31.6%. And look at that compared to the I'm going to go into that data actually. Let me show you that next. So this is kind of a cool slide. It's busy, but I'll show you the pertinent points. This is a waterfall plot showing you each line here represents a patient. So there's 450 plus in the epi arm and the control arm. No biopsy is a blank space. Benign or Gleason grade 6, a grade group 1 is a light blue. Then the dark blue and the gold are the high-risk prostate cancers. And you see here, each line represents a patient. Here is the EPI score. And you see there's a concentration of the dark blue and gold in those patients with the EPI test, actually in both. There's a higher concentration of these higher risk prostate cancers in the higher EPI score. But what's interesting to see here is when the EPI score was utilized in that 15.6 cut point, that no high risk grade group 2 or higher were missed with that, okay? And as you go to the higher scores, there's these grade group 2 or higher. You see what's scary is in the control arm where EPI test wasn't utilized, there are a lot more holes here. These are a lot of patients who chose not to have biopsies in the control arm because they didn't have the EPI score. When physicians, urologists had that EPI score to explain to the patient, there's a much greater compliance and a lot higher detection, 30% higher detection of high-grade prostate cancer. It's a great slide. When you look at projected missed high-grade prostate cancer due to the deferral rates for whatever reason they chose to defer, we know the high-grade prevalence rate is 32%. So in the epi arm, with the less than 15.6, 69 patients chose to defer. We missed 6 high-grade prostate cancers. This is projected. In the patients whose epi score was greater than 15.6, 125 deferred, we would have missed 40 high-grade. Compare that to the control arm, where 61% of the patients deferred biopsy, looking at a 32% prevalence of high-grade prostate cancer. We missed almost twice as many high-grade prostate cancers. Now, this is a busy slide, but this is the subset of the biopsy results in the African American group. And I just want to focus you here. In the epi arm, 68 patients out of 102, 67%, their epi score were all above 15.6 who underwent biopsy. None had an epi score less than 15.6, compared to the control where only 46% of the African American patients out of 115 underwent biopsy, okay? What we found here, So overall, 91% of the African American group had an epi score greater than 15.6. But in the epi arm, the ones who were biopsied, 100% had an epi score above. And what we found right down here, this is looking at Gleason grade group 2, Gleason 7 or higher. There were a total of 29 high-grade prostate cancers detected, 43% of those who underwent biopsy, compared to only 16 or 35% in the control arm. Okay? So there was the increased compliance will identify more high-grade prostate cancer in the high-risk African American population. The biopsy, high-grade prostate cancer biopsy rate is 43% high-grade in the epi arm compared to only 35% in the control arm. When we look at the performance in the validation trial, the CareFirst validation trial, the area under the curve compared to the other two validation trials, it was identical. The AUC was 0.69 in our utility trial compared to 0.7 in the validation studies. So, summarizing the utility trial, when implementing the exosome prostate test in a real-world clinical setting, patients showed increased compliance with the physician's recommendation to defer biopsy when the score is below 15.6 and to proceed with biopsy when it was above. 23% of the patients deferred biopsy based on the epi test when we looked at the questionnaires. In the standard of care setting, many high-grade prostate cancers are missed because those high-risk men choose not to undergo a biopsy. So it's a greater detection of high-grade prostate cancer, 30% more when utilizing the epi test. So that's it on the utility trial, and I want to touch briefly about the newest at-home epi test. We implemented this during the COVID-19, where we were doing a lot of telemedicine. And here you see, I don't know why they put a picture of Dom DeLuise wearing a wig as the urologist doing a telemedicine, but it was very helpful, I found, because number one, the test does not utilize a digital rectal exam, and when I'm on the phone with conducting telemedicine with patients whose PSA may have risen, I was now able to send them a kit at home where they collected it at home, put it in an ice pack, shipped it FedEx to the company, and I would get the score back. If they were high risk, over 30, which gives you a greater than 30% chance of having a high-grade cancer, I would do biopsies. We were doing biopsies on only urgent cases, so it was very helpful during the quarantine. But also, I just want to touch upon the fact that a lot of times and this is one of the drawbacks I will say of this test, is it doesn't fit so well in our normal flow of seeing patients. We often have a patient come in, the medical assistant will see them, get their vital signs, maybe draw their PSA, get a urine test, and have them wait in the room for us. If we look at their PSA and say, oh, you know what, I want to get an epi score and do the test, we can't do it because they've already given a urine test. And so we have to plan on them coming back. But now with the at-home test, we can get their results and say, you know what, I'm going to have you do the epi test at home, because they can do it voided first in the morning when you know their bladder's been full and they're loaded with these exosomes. And so it's really convenient to have this service offered by Exosome. And so this is available now. Here's a sample of the case report form that we get, and it's a binary result with a simple cut point here. Green means your score is less than 15.6, and you can choose to defer biopsy based on your discussion with your urologist. And if it's above 15.6, you proceed with biopsies. And I want to point out, from the validation studies, it does, the epi score does correlate with the risk of high-grade prostate cancer. So in patients whose score is above 30, they have a 30% risk. 40 is a 40% risk of high-grade prostate cancer. And above 50 carries a greater than 50% risk of high-grade prostate cancer. And again, this is based on the pooled analysis of over 1,000 patients from the validation trials. So this really gives us strong data to be used in conjunction with a PSA and other tests when we meet with our patients. So let's go back on the micro level to those 3 patients who we saw. One of them had an EPI score of 8.3 and had a biopsy, and there was no cancer detected. So that's somebody who we could have deferred biopsy. The other patients had EPI score well above 15.6, and one had a Gleason 8 and one had a Gleason 7. So this is where this is very helpful in counseling our patients whether to proceed with a biopsy or not. So in summary, the test is a random urine after 1 hour of not voiding. No DRE is necessary for men over 50 with an elevated PSA of 2 to 10. It looks at 3 genes that are associated with prostate cancer. It does not have to take into account the standard of care parameters. It's a standalone test, and it can help urologists navigate the biopsy decision process and cut down on unnecessary biopsies and putting patients through the stress of going on active surveillance protocols. And just my patients get really amped up when they know they have to come in for a biopsy. No one likes it. It is completely non-invasive, urine-based, simple to collect, and the negative predictive value is over 90%. We have strong, relevant clinical validation data and the clinical utility study that supports its efficacy. We can avoid 30% or more of unnecessary biopsies, and this test is included in the May 2019 NCCN guidelines for screening for early prostate cancer. And these are the relevant publications in no particular order. And so with that, I want to thank everybody for their time and attention. I hope that you found this helpful, and I will open the field to any questions. Thank you.
Dr. Tutrone, thank you very much. It was an excellent presentation. We have some questions that came in, and a reminder to all that if you have any questions that you would like Dr. Tutrone to ask, please enter them in the question or the comment box on the toolbar. So one that came in, Dr. Tutrone, was, can you describe what the criteria was for standard of care in the study, and did it differ site by site?
That's a great question, and this is where it's a utility trial. There were no rigid criteria. The only criteria was the patient had to be over 50 with a PSA between 2 to 10, no prior history of prostate biopsy, and the only other thing in the inclusion I didn't say is they couldn't have any, they couldn't be on any 5 ARIs, finasteride or dutasteride that could affect their PSAs, but it was really a decision that was made by the urologist. The treating urologist chose the patient because they were considering doing a biopsy in these patients. That's the only criteria. And they could utilize any other test they wanted, such as a PHI test, a 4K, PCA3, whatever they wanted to use. And so it was the individual urologist's decision. But what's important that every subject had their own urologist, and it was not changed throughout the study. It was continuity of care throughout the trial, and we are collecting data out to 5 years following these patients.
Thank you very much. Another question that came in was, how has your EPI or ExoDx Prostate utilization changed since you have analyzed the data from this study?
So I've always been enthusiastic about this test. So the study only supported my belief in this. I mean, I looked at the validation studies very carefully, and I liked it. But in the real world setting, our utility trial, where 39% of patients underwent biopsies, 61% chose not to, it really confirms with me that we're missing a lot of high-grade prostate cancers and doing a lot of unnecessary biopsies. So to me, it really reinforces the need to utilize this test in those patients who are in that gray zone, 2 to 10. I mean, clearly patients whose PSA is over 15, over 20, we're going to do a biopsy no matter what. I don't need that test. But this study only reinforced my belief in this test. I've always felt we need something more than PSA, and this is easy to collect and really has strong data backing its utilization.
Thank you so much. Another question that came in was, what would you do with a patient with a slightly elevated PSA around 4, but with an epi score kind of in the range of 16 to 20?
Yeah, that's the gray zone. And I'm often, if they have looking at other factors, if it's a benign digital rectal exam, if they have no family history of prostate cancer, if their PSA velocity is really not high, so if they went, say, from 3.5 to 3.7 to 4, and their epi score is less than 20, I'm probably not going to biopsy that patient. I'll follow them up in 6 months, but I'm not going to biopsy them. If their PSA, on the other hand, went from 0.5 to 2 to 4, even with the epi score in that less than 20 range, I probably would biopsy them. And again, I'd take age into factor. So again, it's a moving target. There's a lot of factors to take into consideration here.
Absolutely. Thank you. We got a couple more questions. So the time, one about the at-home collection kit. Can you speak to how patients respond to the at-home collection kit, and is it easy for them?
Yeah, so I will touch on that. Most patients love it. It's easy. They have to make sure they follow the directions. It comes in a package with very clear instructions. I do call the patients beforehand and remind them that it's most important that the freezer packs are put into the freezer immediately when they open that, so that they're frozen and ready. When they give the sample the next morning, they pack it in the box with the freezer packs and call FedEx. It's free shipping. So it's really pretty easy. They have to make sure they screw the cap on tight, and there's instruction in there how to use the collie pee, and I make sure that they point the short end over the toilet and not onto their shoes. And the only thing I will counsel you is to make sure that with a lot of commercial carriers, that's the only problem I've had, is some of the commercial carriers denied it, and patients weren't happy when they got a bill. And so now I'm a lot more careful about getting prior authorization in some of the commercial carriers, but in the Medicare and Blue Cross Blue Shield, it's not a problem.
Thank you. And last one, because we're coming up on time, would be, why wouldn't you automatically biopsy an African American patient or another patient at higher risk? Why the need for epi?
No, just because they're African American, I wouldn't biopsy them. Epi is going to be helpful in discriminating the patients who are at very low risk. I don't like to have to put patients through a biopsy unnecessarily, and so just because they're African American, I'm not. Their overall incidence of high-grade prostate cancer was about 32%. So you're going to get a lot of negative biopsies and put patients through unnecessary biopsies. I do take it into account that they're African American, but just because their PSA is in that gray zone, I don't do a biopsy. This test helps me discriminate which ones are at higher risk.
Thank you so much, Dr. Tutrone. I really appreciate your presentation, and everybody for sending in the questions. Thanks everybody for joining us today. As a reminder, the recording of this presentation will be available in about a week on www.exosomedx.com. And as right now, this concludes this webinar. Thank you all again very much.